So, on the topic of antibiotics, nearly all patients received antibiotics, but only a minority had access to advanced wound therapies or vascular interventions. What are barriers that exist to broadening the adoption of these interventions in underserved populations?
Right. So I think one of the key take homes is when you use antibiotics, antibiotics are not for wounds, they're for infections. So just because someone has a wound does not necessarily mean that they need antibiotics. Also, picking the right antibiotics is something that's important. We didn't publish it yet, but we found that most of our patients had MSSA as the cause of their infection. But routinely, we're covering for things like Pseudomonas and other really big, using big antibiotics, stronger antibiotics to cover for things that are not necessarily causing your diabetic foot ulcers. So it's really important to look at where you are and see what are the most common causes, because you may be overtreating with antibiotics. In terms of access, access has a lot to do with where you live, your socioeconomic status. So studies have shown that if you live in areas that have a low index when it comes to poverty, you definitely will have more access to things as opposed to someone who lives in a higher poverty indexed area or an area of higher disparities. So I know one of the problems we've been having in the Bronx is that a lot of our pharmacies are closing. So before, you might have only had to walk 5 blocks or 2 blocks to get to your local pharmacy. Now you may have to walk a mile or go further. And again, if you have an ulcer and you're supposed to be non-weight bearing, you can't do all this walking around. So that's definitely been an issue with access to getting medications, is that the pharmacy closures have been disproportionately affecting communities of color.
Hmm. Your study highlighted the importance of multidisciplinary care. What models have you found most effective, and what are some of the challenges in implementing them in resource-limited settings?
Excellent question. So right here at Stanford, they actually were one of the first places to have a multidisciplinary care program, and they were actually able to decrease the rate of amputation. So they had vascular surgery, internal medicine, podiatry, a wound care nurse. And what they found is that when they brought people in, they did this early intervention. Again, this is this early vascularization. They were able to reduce amputations by about 38%. And when I saw that, I was like, this is great. We need to do this, because clearly we too were dealing with a high rate of amputations. So in March, we started our first multidisciplinary clinic. It's endocrinology, infectious disease, behavioral health, podiatry, and vascular surgery. We come together, the patient comes, we rotate between the rooms, and we each see them individually, and then we come up with a plan and we follow them out for a year. So some people, you may want to see them back in 1 month. Some people, you can get away with seeing them back in 6 months. So pretty much we will take anyone who has an active diabetic foot ulcer, a chronic foot ulcer, or anyone with a foot deformity, because we know that if people have foot deformities, that's also going to increase their risk of developing a diabetic foot ulcer down the line.
And when you say foot deformities, are you just talking about regular bunions, or what are some of the more
There
common
are
ones?
all types. So bunions is definitely one. You commonly see it in especially women who wear high heel shoes, or men that wear improper fitting shoes for work every day. You can also see high arches over time that develop in people with diabetes, or something you commonly see in our folks is being flat-footed and you don't have proper arch support. So that also can set you up for getting ulcers. So those are some of the different, also forgot hammer toes, where your big toe crosses over your second toe. So those are some of the common deformities you can see.